Oh, I think we're live. All right, people. It's another Sunday night here in Ohio. So welcome to Bite-Sized Learning. I am Dr. Mike Sevilla. I am your President-Elect of the Ohio Academy of Family Physicians. How that happened, I don't know, but we'll get into that later. But we have a very exciting topic tonight. And I've known Dr. Rood for a long time. He's been speaking on this even before 2020, even before COVID-19. Dr. Mark Rood, thank you so much for the time tonight.
Thank you, Mike. Thanks for inviting me. I just want to mention that I work for the Cleveland Clinic, but I'm not speaking for the Cleveland Clinic in this presentation. I don't want to have my words interpreted as speaking on behalf of the Board of Trustees. They haven't given me that power, but I am happy to give you any information I can from my experience working in telemedicine for the past 5+ years.
Yes, and I guess I'll give my disclaimer too. The words and opinions expressed here are not necessarily those of the Ohio Academy of Family Physicians or the Board of Directors, just two guys talking. Mark, let's just kind of jump into this. So, I know you have a lot to say about telemedicine as a topic and as, a potential kind of, leadership for family medicine. Why don't we just kind of back up a little bit, just to share a little bit about kind of your, initial exposure to telemedicine, your initial type of interest in telemedicine.
So I was asked to help start the Cleveland Clinic's venture into telemedicine called Express Care Online back in 2015, when Toby Cosgrove, our former CEO, had been crying to get it started ever since 2012. And by 2015, no one had really taken the gauntlet to get this off the ground. So he, like Khrushchev in the 50s, when he wanted to go to Disneyland, he banged his shoe on the table and said, by the end of this week, you need one family doctor, one internist, and one pediatrician, or heads will roll and people will be fired.
Wow.
So my my department chair came up to me and said, I heard that you had dabbled in some telemedicine before. And my dabbling was that I was a consultant for another insurance company who was trying to start telemedicine because Google, one of their clients, had said, we won't sign a contract unless there's telemedicine part of it. And they showed it to me and I sort of said, I'm not sure that this is for this program that I was working with the insurance company on, and sort of turned it down. And because I had that experience of having seen it demoed once, I had more experience doing telemedicine and primary care than any other provider at the Cleveland Clinic. So they asked me if I would be willing to dedicate 50% of my clinical activities at that time, which is now down to 30%, but 50% at that time to get the thing off the ground. And I had to tell them by the end of the week. And then my department chair called me in the middle of the week and said, we lied. You don't have till the end of the week, because if you turn us down, I need to find somebody else, because I don't like my head disconnected from the rest of my body. So I met with the other members of my team. I said, sure, I'd be willing to give this a try. And that was 5 years ago, back when, wow, even though they said, oh, this will be easy because you're a researcher, so you're complaining you don't have enough time to do research, so you'll be in front of a computer and nothing will happen because nobody knows about this. And it's all turnkey. It's we have the platform and there's nothing you have to do. Well, from a business point of view, there was nothing that had to be done. But from a medicine point of view, everything had to be done because it was a blank screen. There was nothing there. There were no protocols. There were no templates. There was no way to describe how the Cleveland Clinic actually does telemedicine and does it with quality, which most of what we do has quality as job one. So developing all that, writing the protocols, writing the procedures and workflows, and what could and could not be done well. It's one of the reasons why I said yes, because I thought there needed a gray-haired person in the room to have the experience to say, this is something we should be doing with telemedicine, and this is something we shouldn't be doing with telemedicine. And that's served us well as we've developed a platform from like seeing 3 visits a month to before COVID hit 4,000 or 5,000 visits a month for our team. And during the pandemic in April and May, we were seeing 200,000 patient visits per month. And so we had that experience to be able to ramp up quickly when we needed it with this pandemic. And I think that those early years of development allowed us to flip the switch for other people to get involved quickly because we had the experience of bringing it on a smaller scale first.
Now, on the startup, were you there purely on a clinical basis? Do you have computer science background to do like coding and stuff, or what was it?
I've always been nimble with computers. Before I joined the clinic, I started using their electronic medical record. I was paying for it out of my own pocket, and they gave me from this computer store where I was trying to get my computers, because at that time with the Stark Amendment, the provider needed to buy the computers, and you could share the cost of the software, 85 on part of the hospital system and 15% on behalf of the provider. Back in that day, they were asking me to spend $50,000 on computers and software, and I didn't have $50,000. I had $5,000. So I built all my own workstations. I built 20 workstations from scratch, and I used eBay parts and bought things used on mostly on eBay. And the only thing I bought new was a server, and I had someone help me program the server, but I did all the rest of the programming. So I'm sort of self-taught and had an interest over the years, but so I've not been computer phobic, but I wouldn't call myself an expert on the hardware side. On the software side, I think we needed good software that was HIPAA compliant, and that's a discussion for now and the future as well. Because even though HIPAA rules are currently sort of suspended a little bit, we anticipate that that's going to change back fairly quickly to needing to be an encrypted or HIPAA compliant platform moving forward.
Yeah, this is so fascinating to me, because I've talked to very few physicians who have had a computer science background, and to be in your type of position, to be kind of like from the ground up, from telemedicine. So what was your approach for like a telemedicine interface, documentation, shifting from an in-person interaction to a totally telemedicine? Can you share a little bit about your thought process on this?
Our thought process was that the standard of care should not matter. You should be held to the same level of standard of care as you would as if you were seeing a patient in the in-office environment. And that I looked at telemedicine as sort of like a telephone. So when Alexander Graham Bell said, Watson, come quick, I need you, that could have been perhaps the first telemedicine visit. And so the fact that we can see video enhances that capability for us to do a better job of what we do, but it doesn't change the fact that the computer and the video and the audio is just a tool for us to be able to do what we do day in and day out, all day long. And it gives us just several new opportunities. We can see in a patient's home, which we can't do when they're in their office. We can look in their refrigerator. We can see them in their bedroom. We can hook up little devices to the telemedicine visit, so we can actually, if you go to Best Buy right now, I'm not giving them a plug, but if you go to a computer electronics store for $299, and sometimes they're discounted down as low as $150, you can have a device in which it comes as something that allows us to look through telemedicine in the patient's ear, and take their temperature, and listen to heart sounds, and listen to breath sounds, and serve as a flashlight to look in someone's throat. And we can take pictures of that. We can have remote monitoring devices in which EKGs can be uploaded, or have Bluetooth-enabled blood pressure devices. So Medicare compliant uploading of data so that it would actually be counting as a true blood pressure. As long as it's Bluetooth enabled, it counts. And we have those devices that we prefer at Cleveland Clinic, and we have a list of which ones have stood the test of quality and which ones have not. Same thing for treating patients who have chronic diseases, for which the exciting thing about this experiment with COVID in the past 3 months has been that I've actually, instead of seeing on-demand patients from all over the 18 states on which I'm licensed, I'm seeing my own patients, and I'm being able to render care for CHF and COPD and chronic disease management. And we can use Bluetooth-enabled scales if patients are so inclined to get one, or we can just write down what scale they have and then do a much better job managing their CHF and other disease states, because we essentially look to develop protocols for, or in my previous years, I was a care pathway development. So what is the care pathway, not just for CHF management in the hospital, but what's the care pathway for outpatient management of congestive heart failure? What should be the care pathway that maximizes our ability to use these visits, these telemedicine visits, as early warning radar indicators for patients who are having their health decline, so we catch them before that happens? And there are things we can do.
Now, you've already mentioned some of the, some of the diagnoses, some of the advantages of using telemedicine. Feel free to add on to that and maybe just, touch on a little bit, are there certain diagnoses or certain patients that are not appropriate for a telemedicine visit?
Well, as my OBGYN colleague reminds me when I see him in the shopping center, he says, I still have a hard time figuring out how to remotely deliver a baby. I'm sure that's been able to be talked through in other settings, and we certainly know of first responders who've in 911 have helped people deliver their own baby, but we don't want to do that on a regular basis. Certain things in which you really need to feel the patient, abdominal pain, we have certain ways on the physical exam. I not infrequently have a patient who I'm worried about retroperitoneal signs or other things like that, where I can get them to hit their own kidneys or jump up and down a few times. If you have peritoneal signs, you're not going to want to do that if your appendix is about to rupture. But feeling a hernia is really tough to do. No matter how long my arm is, I cannot get into the inguinal canal that way. Things like that. But we have protocols and evidence-based medicine to support things like the Ottawa rules, where you can say, for managing a patient who has a sprained ankle and trying to figure out if they need a x-ray to rule out a fracture, these rules were initially developed for clinicians, but they can be taught to patients on how to examine their own ankle in the right place, and that can help tell you whether this patient needs an x-ray or not. So knowing these little tricks, understanding that just because you're doing a virtual visit doesn't mean that you do not have a physical examination. I have some providers who've written physical examination not performed because it was a virtual visit. And that's just flat out wrong, because there's a lot of information that you can obtain in multi-organ systems that allow you to be able to accurately support your diagnosis, to be able to then say, based on your history and physical examination, now you got your assessment, you got your plan, you know what to do. And it helps that I have 32 years of clinical experience in family medicine as an experienced senior physician. And I use that every time that I'm seeing a patient, be it in my office or in a virtual visit.
Now, we've talked a little bit about payment and payment of telemedicine visits. Can you outline a little bit kind of the pre-COVID rules and the changes that were made since then, and then the changes back that our office is seeing? Maybe outline that a little bit.
Right. So during the height of the pandemic, we were seeing in my office, I only saw, I think, 4 patients in the bricks and mortar office that entire month. So 98% of the patients that I saw, maybe even 99%, were through telemedicine. And both the federal government had waived many critical rules to allow that to occur. Some of the rules that they waived the HIPAA requirement, so that you did not have to necessarily always connect through a secure platform. They waived, so you could use FaceTime, you could use Google Duo, And we made it easier for our clinicians to be able to make those visits possible if there were problems initially getting onto the secure platform of Express Care Online. Because of volume issues, we found that one platform probably wasn't sufficient because it just couldn't handle all the volume and bandwidth to see 200,000 patients a month. So we extended to introduce Zoom, attaching it through our My Chart patient portal app, which linked with Epic. And that was an advantage not only to our system, but it was also an advantage in being able to be an encrypted but easier version than even the Cleveland Clinic's Express Care Online was, because it was just being overloaded with volume. And the clinic also chose initially to waive copays, not just for COVID-19 patients, but also waive copays for anyone seeing anyone for any reason at any time through the virtual visits, because they were all, we figured, COVID-19 related in some way. The fact that we weren't seeing them in the office was COVID-19 related. Now, the federal government is going to very quickly take issue with that and has put out certain rules about what is a COVID visit and what is not. And as such, realizing the need for us to tighten that up, the clinic is, as of July 1st, I believe, choosing to start copay requirements being patient responsibility for non-COVID related visits, but still COVID visits by the waiver from the federal government currently exists and exists after July 1 as well. That was huge because not only previous to this did Medicare patients until very recently be required to go to a underserved site of a provider office and initiate the visit from there, but they had to be in a healthcare service deficient area to qualify for a telemedicine visit. All those were waived. And as we still are working under pandemic rules, those waivers are still in place. The concern that we have moving forward is, I think the healthcare community has seen the value of telemedicine because many or most providers have had at least some telemedicine visits during this time. As the federal government looks at the idea of pulling back on waivers and pulling back on calling this a pandemic, it could potentially affect how CMS makes its rules and private pay insurers make their rules moving forward. I would submit that it would be a tragedy for telemedicine to be put back into the box that it was before COVID-19, because it is the most cost-effective, not just for providers, but cost-effective for patients. Patients can do this from their workplace. Patients can do this from their home. Patients can do this, and instead of having to be checked in for a visit by a nurse or by a medical assistant or nurse checking them in with 12 minutes of vital signs and other things, your visit could be entered as easily as 45 seconds from the moment that it's there. So it's using the patient's time, which is valuable too, recognizing the need for that. And there are no facility fees because you're not doing the visit in a facility, you're doing it in a patient's home or the workplace or the like through telemedicine.
Yeah, and I'm just going to share some of our experience from our office, and we've seen a lot of my patients even before 2020 utilizing telemedicine through an employer, but it would be at a work site and it would be not with us. It would not be with their family physician. It would be with somebody who they have chosen to do that. And when we have looked into telemedicine, pre-COVID, rules, insurance company would say, "Oh yes, we have telemedicine available, but it is through our insurance physician."
Right.
And obviously that's very frustrating. What are your thoughts on all that? And have you had experience with running into that with your patients in the past as well?
One of the reasons that the insurance companies justify taking that approach is that, like when they approached me asking, "Would you be willing to start doing telemedicine visits for your own patients in your own population? My initial response was no, in part because insurance companies weren't paying for it. And to blend in virtual visits at the same time that you're seeing patients in office, because they're different workflows, it's hard to do that. It's hard to integrate that no matter how adept you are at scheduling. If you're seeing patients every 15 or 20 minutes, then one being a one-off of a telemedicine visit and then going back to an in-office visit, it actually makes your scheduling pretty complicated. So one of the tricks that we found is that having blocks where you're doing telemedicine only and blocks when you're doing in-office visits only, and trying not to have the twain shall meet, just makes the life of a practitioner easier. But certainly the best quality care is when the patient's primary physician is seeing them, be it in an in-office visit or a virtual visit, and we can prove that every day, including Sunday.
Yeah, and just to kind of share a little bit about our experience. I mean, we probably had a similar experience to your office there when the rules were relaxed. We worked with our electronic record company, and they had video visits available. They were waiving fees to us and all that kind of stuff. So we had I wouldn't say a negative experience, but I mean, obviously, just we're still kind of in early days with this. Mm-hmm. We saw a similar uptick in that, and obviously a lot of family physicians is just to get the care done, not matter how that is, and we saw a significant uptick with that. But yeah, we had growing pains too, as far as we still had our office open, we still had patients actually coming in, and then we were trying to mix in the video visits with that, and like you're right, we learned, like everybody else, it is a different workflow. And as things kind of shift back, or as the rules change again, we as an office are trying to figure out, how we're going to do it, or if we're going to do it, or that type of thing. So, I mean, as you talk to family docs, I mean, are you seeing kind of that changes too, or that experience similar in people that you're talking to?
Absolutely. I can say that the piece that kept us persisting in trying to get telemedicine up and running, because I had experience doing telemedicine visits, but my partners didn't. But now all of them are adept, including our nurse practitioners, in doing telemedicine visits. And the thing that drove us to make this work was we knew at the time when the pandemic was just starting, and the rules from the state of Ohio with Governor DeWine were implemented, we knew that the safest place for us to keep patients were in their home. And so if we could keep them in their home and we could find a way to still give them access to care, we said, we got to find a way to make this work. And that's exactly what we did. And it was the safest way to manage those patients at the time. And it was the safest way for us to be protected, given the fact that we were trying to keep ourselves from going through PPE and help still meet the needs of our patients in the best possible circumstances. And even though we missed some of the things, like I would have loved to have had some blood pressures, I would have loved to have had some INRs done, as we were typically doing them in the office, and we didn't want everyone to necessarily go to labs unless we were sure the labs were safe early on, and we calculated that, well, this INR could probably wait another month since it had been so stable. Yeah, there were a lot of things that we wish that we could have done better, but we're doing a pretty good job managing patients in the way in which we were doing it, recognizing that it wasn't perfect, but it was pretty good.
Now, you've been doing this a long time. I mean, do you have, maybe a few tips and tricks to family docs out there who may be struggling, or maybe having a tough time, or maybe didn't even do any type of telemedicine, but just still kind of trying to think about it, how they can integrate it in their workflow in the office? Sure.
We still employed all of our medical assistants during this time, even though we were seeing a few patients in the office. So we put our medical assistants in charge of helping set the visit up for the patient and pre-take their initial reasons for entry and what was going on with them, and try to fill out some of our templates, not only asking about COVID-19 questions, but helping tease out a little bit more, because they were all experienced medical assistants, about what more the patient's concern was, so that it saved time for the providers. And we were so successful at doing that, that even in our patients that we were bringing in the office, to minimize their time being in the office, instead of waiting for them to hit the exam room for the medical assistant to take that kind of pre-visit summary, we were still doing those pre-visit summaries over the telephone before the patient arrived, so that the only thing that the medical assistant had to do when the patient finally arrived was that their blood pressure vitals were taken. And then the rest of the note was complete from their perspective, and the physician could go in the room. So it minimized the time that the patient was actually in the office, and allowed us to do the same on the exit. So instead of patients stopping at the checkout window to schedule their next appointments and the like, our front office staff would automatically send the patient out, tell them that we'll be contacting you later by telephone, and all the information that was done at the checkout counter was done. It was just done again over the telephone, so the patient didn't have to spend any more time in our bricks and mortar office than they absolutely had to.
And I don't know about your patients, but I mean, a lot of our patients we had, especially at the beginning, we had to do a lot of education about what telemedicine video visit means. How did you do that with your patients?
So some of our patients were getting familiar because they were more informed. In the Northeast Ohio market, we've been advertising telemedicine through the Cleveland Clinic for a while. And many of them knew that I was doing telemedicine, but I wasn't necessarily doing it with them. So we had had some of these conversations before. But also, we made it easier because I think one of the turning points was when we integrated our EMR and Zoom all through the MyChart portal, which is the patient portal that the Cleveland Clinic uses. So instead of sending them to a different website and a different company to get what they had to download in order to make a telemedicine visit work, it was all through the patient portal. So it's all integrated. The patient only went to the site that they either were familiar with, or the site that we were saying, okay, if you have to download one software, let's download your patient portal. And then that's something you'll be able to use for the lifetime of care as long as I'm your doctor, and all the other providers in whom I'm associated with. And that will then, through that platform, we can get you onto Zoom, and we can get you onto other things if it's all directed through the patient portal. And so we made that decision early on as we were trying to improve throughput and patient information, so they didn't have to go to multiple sites. Everything could be done from within the Cleveland Clinic site. Now,
of course, the long-term viability of telemedicine. Obviously, a big part of it is the payment model and ensuring some kind of payment model. From other things, whether it be from a policy standpoint, or maybe from your office standpoint, or from a family doctor standpoint, what other steps do you think to make telemedicine a long-term treatment option? Maybe not the 100%, but as a treatment option for family docs.
Yeah, I think CMS and other insurers are going to be looking at this, and I doubt that we're going to be putting the genie back in the bottle. I do believe that there will probably be a requirement that the reimbursement for telemedicine be a little less than in-office visits. Right now there's parity, but I think that's temporary. But the little less should be a little less. It shouldn't be a lot less. It shouldn't be 40 to 60% less than an in-person visit. If I had to guess what I think the right price point is about 85% of the visit for an in-person visit. 85% of that reimbursement should be available, especially in primary care. Primary care is really not just hurting because of the number of independent doctors that we have doing practice who are not hospital-owned, but even the hospital-owned facilities and providers are struggling because of the devastating effect that COVID had on our ability to pay the bills. And the work that we are showing that can be done in a virtual manner has to be incentivized for us to be able to continue it. And I think it would be a mistake to say, okay, well this was fine during COVID-19, but we're going to go back to seeing every person in a bricks and mortar visit. We know now that patients who have upper respiratory infections can have that very well attended through a telemedicine visit. We know that the safest way to see a patient who might have COVID suspect symptoms is safest for the provider and safest for the patient to be initially evaluated in a virtual visit. And that's going to continue to be the case, not just now. As Ohio, we can argue about whether we're ramping up or ramping down. But when cold and flu season hits, the utility of telemedicine before we have a vaccine and before we have an effective outpatient treatment is proven. And even for non-COVID related illnesses, we know that patients were not presenting to emergency rooms with MIs, not because they weren't having MIs, but a number of patients were having MIs, but fearful that they would be sicker if they went to the emergency room than if they stayed home. And that's dangerous for some diseases with our chronic unstable patients with congestive heart failure, MIs, appendicitis, et cetera.
Yeah, I can definitely reflect on a lot of things that you said. I mean, our office is physician owned. We're not hospital owned. We're one of those independent family doc offices in small town Ohio, small town America. And exactly right. I mean, before this telemedicine rules changed and before the CARES Act and all that stuff, I mean, we were really wondering what was going to happen to our office, or we're going to have to lay people off or that type of thing. What was going to be the effect of that when we have the hospital across the street and the hospital owns offices across the street? What were going to happen to them? So a couple other questions before we bring in our special guest. I know the answer to this, but I just wanted to kind of launch on this. Mark, I presume that you would want, some kind of telemedicine curriculum to be in med students, residency, that type of thing. One, have you been approached about that yet? And two, kind of what would that look like? Because I've in talking to people, obviously residents are like, we've never been taught telemedicine. So what would a curriculum kind of look like to teach learners about telemedicine?
Well, I actually have some experience because I'm the clerkship director for a 2-week telemedicine elective that we provide for fourth year medical students affiliated with either Case Western Reserve University, School of Medicine, Cleveland Clinic Learning College of Medicine, which is also an offshoot of Case, but it is a separate medical school. And then we also have it available for OUHCOM, Ohio University Heritage College of Osteopathic Medicine students in the Cleveland area. So I've been running this clerkship for 4 years. We've had perhaps 30 students rotate through the clerkship over those 3 years. And we've extended it now to APP students and some physician's assistants. We've developed a curriculum for residents, and we've developed a curriculum for fellows to give them at their level of training information and expertise on how they can do not just learn the business aspects of telemedicine and most importantly, website manner and get real hands-on experience seeing patients through the telemedicine platform, but also research opportunities, which are important for residents and fellows. I've participated in 6 articles that have been published in peer-reviewed journals on the subject of telemedicine, mostly in the areas of quality, like antibiotic stewardship and whether patients have a shorter or longer visit or rate their provider more or less based on certain factors, and whether those ratings or the length of visits are appropriate. Whether we're incentivizing the right things. And there's tremendous opportunity for doing more of that. So we have a curriculum that could be as good as first year medical students as it is for practicing providers, because we had to use some of that experience when we were taking our 2,000 plus Northeast Ohio providers from all specialties and suddenly had to give them a few quick videos or a few quick links to get them up and running to be able to do telemedicine visits. Just because you can do it doesn't mean that you're doing it well. So we've taken the initiative for our providers to say, there are some core competencies that you need to be signed off on so that you are credentialed in telemedicine. And we take those very seriously, and very similar to what we ask the medical students and residents and fellows to also do. So as we get more mature with this and build it more into our workflow for all providers doing telemedicine, it's the only way that you can take quality seriously.
And you'll see in the scroll below, you'll see an article that Dr. Rood wrote. And as before we bring in our special guest, I just wanted to allow you to, is there any closing thoughts that you have on this topic, and maybe talk a little bit about your article?
Sure.
We kind of shift gears.
No, that's great. Yeah, I was asked by John Hickner, who's the executive editor of Journal of Family Practice, to write a article from a first-hand perspective about what it was like to be doing telemedicine and then COVID hit. And it was very simple. We saw an uptick in volume, not of COVID cases, but of people using the platform more. And so my director asked if I would be willing on a Saturday, which I don't normally do telemedicine on a Saturday, get on for a few hours just to pitch in. So I pitched in, and it was like trying to drink from a fire hose. There were already 38 people in a queue, and all I did was click that I was available. And that was just in the first minute. And if I had left myself open, I would have had 38 more and 38 more and 38 more and 38 more. Literally thousands of patients were waiting to see a doctor. And so I said, okay, I'll do something with these 38, but I'm not sure how quickly I can do it and what I can do. But I triaged the best I could, and I got through the list as quickly as possible. And I realized that patients, those 38 stayed. They stayed for the 3.5 hours that I was on, from beginning to end. And these are patients who, before COVID, if there was a 30-second wait time, they'd click and then they'd click out of the visit and they'd say, oh, I'm not waiting. These people stayed for over 3 hours waiting for a physician opportunity to talk about their concerns, much of which was COVID related. And COVID related before we really had a playbook of how we were going to manage all these patients. We had some education about COVID, but we didn't have as much information and tools and CDC guidelines as we have now. So that's when I turned from the email that I got originally asking if I would go online. I returned the email. I said, Matt, I think we're going to need, or my quote was, you're going to need a bigger boat. Channeling Jaws and Roy Scheider, for those of you who don't have as much gray hair as I do. I was in high school at the time when Jaws came out, and it obviously made a big impression on me at the time. Seeing Jaws in a movie theater instead of seeing it on video, it's a big difference. And the just deadpanning, you're going to need a bigger boat. That's what it just flashed into my head was what we really needed, and that's exactly what we did. We not only ramped up 200 providers who volunteered to help us with the on-demand online platform, but we also put out this whole initiative to train the 2,000 plus providers across multiple specialties, as well as a whole army of nurse practitioners, physicians assistants to get us up and running. And it was a process that allowed the Cleveland Clinic to shift in seeing tens of thousands, hundreds of thousands of patients within a couple weeks. And we were told by the federal government that we were the institution that did this fastest of any other institution in the country. And it was because I think we had the prior experience and we had the tools in place. We just needed to get them out to more people. And so we helped with having training sessions every day, several times a day, live training sessions where providers could get on. We trained staff. We put out digital playbooks, which are now a national standard, put out by Health and Human Services. And within the article that you can get on the link is a playbook that you can look at that's updated regularly. And that's a link to our playbook. And I thank all the members of our extended team and all the departments at the Cleveland Clinic for responding in such a way across every spectrum, but telemedicine being one area where we made a huge contribution. I didn't think when I was asked to put on telemedicine team back in 2015 that it was going to be something other than sort of a thing that we did in the fringes. But this proved the worth of telemedicine, and I'm very thankful we had the experience, knowledge, and opportunity to help improve patients' lives.
Dr. Mark Rood, thank you so much for the time. I mean, for you people out there, we're not done yet, but I just wanted just to say, thank you for your leadership on this. I've been hearing you speaking about this topic at least 4 or 5 years now. And I know you've been at various OAFP venues talking about this, and it's really kind of piqued my interest as I've learned about it more. But obviously, like everyone else, it's very much accelerated in the past, 2-3 months. Thank you so much for the time. Thank you. I mean, I know that people are going to be asking questions. You've been getting questions probably from people from a lot of different venues. So thank you so much for the time and for sharing on this topic tonight.
Thank you for the opportunity.
So we're not done yet, kids. So this is Family Medicine, and what would it be without talking about family? So as our surprise guest, we have Shaina Rood. Hi, Shaina. How are you?
I'm doing well. It's been so inspiring listening to you and my dad talk about telemedicine. And I'm a 4th-year medical student at the Ohio University Heritage College of Osteopathic Medicine at the Cleveland campus. And it just really makes me, want to get involved and learn more about telemedicine. As you had mentioned earlier, that residents haven't gotten a ton of opportunities, I guess, with telemedicine. I feel the same way as a medical student, just wanting to learn more about telemedicine. And in my future rotations, I've learned that some of them are going to be virtual rotations. So I think I'll get some experience and be able to dip my toes in the telemedicine waters. So I'm excited to be able to have the chance to do that. But I've grown up, watching my dad, and he's been a big inspiration to me, getting into medicine and getting excited about family medicine in particular. So
yeah, let's talk about that a little bit. I mean, obviously you have such a positive influence in medicine. I mean, when did you know that this was going to be in your career path? Did you know early on, or was it later on in your schooling that you knew that family medicine was in your future?
Yeah, so I grew up with family medicine in my life. My dad had a private practice, and I worked in his office in high school growing up, so I got a little taste of it, and I loved watching my dad practice medicine, and really appreciated the relationship that he built with his patients, and got to see kind of how he helped the community get healthier over time. So that was kind of like in my brain. I then went to college and got learned about health policy and what I guess now we call the social determinants of health, but just different injustices in the healthcare system. So I decided to get into health policy, and I got a master's in public health. So I kind of took a curvy path to medical school. I worked in health policy for a while before going to school and helped implement pieces of the Affordable Care Act. But I felt kind of removed from the people and the one-on-one relationship that I had seen my dad have with his patients. So I decided that I wanted to work more directly with people and use my health policy skills to kind of meet people where they were at the point of care to help them navigate the system. And I know that family medicine in particular is steeped in a long history of advocacy and social justice. And so I guess my previous experience with my dad and then just learning how the healthcare system worked, I thought as a family physician, I could best use my skills. And then I went into my rotations with an open mind, but I kept coming back every rotation thinking, this patient could really use a good primary care doctor, a good family doctor. So even though I was trying to, think about maybe I would want a different path, I still kind of had the interest and direction of going into family medicine. So, and I really like the fact that family medicine has such a broad scope. Like, you can really do anything. You can go into advocacy, you can go into research, you can focus, your practice in women's health or sports medicine. So I really like the variety and the broad scope of the practice. So I'm really excited to start applying to residency and getting more, building my clinical skills more this year.
So Mark, I see you're smiling there, and if you could put your dad hat on, I mean, you should share a little bit about what you're feeling when she shared with you about going to medical school, and then even choosing family medicine as the specialty that we love.
Well, she's being modest. She actually started interest earlier than she said. We testified together. She was in a snuggly, and there's a picture of me testifying at the NCFPR when she was like 14 months old. And from that auspicious occasion, when she was, I think, 8 or so, she was too big to listen to the clown when drug reps would take us to a movie theater and open up the candy stand and get us in to see Rugrats or something. But so we decided to take her into the actual physician rep portion, and she just thought that that gastroesophageal reflux was the most fascinating thing you could possibly think of. The light bulb turned on at that moment, and the rest is history, as she said. But I think she's, of my 4 daughters, she's the one who, from the earliest time, had the interest in going into medicine. And I didn't try to say that family medicine was the only path, but I think she found it simply because it felt right to her. Maybe it felt right because she grew up in a household that way. We're in a small community. If I stand too close to the entrance of the movie theater, I feel like I'm a Walmart greeter because everyone says, "Oh, hi, Dr. Rood. Hi, Dr. Rood." And that's a privilege because we live in the same community in which I work. I live 1.3 miles from my office, and that small community has learned that there's a Rood physician, ROOD physician in the community, and we hope in the future to have 2 Rood physicians in the community, because I could see Shaina blending in to our practice quite nicely and continuing the legacy of what I started 32 years ago.
Wow. I mean, I can definitely reflect on that. My dad is a retired surgeon, and he was in solo practice here in kind of the Youngstown type area for a long time. And when I started medical school, I wanted to be a surgeon. I wanted to follow his path. And then I did my surgery rotation. I'm like, I can't do this. It wasn't was not a good fit for me. Yeah. And then right around that time,
my feet that long.
And right around that time, I met some of my family medicine mentors who I consider colleagues today, and they said, "Hey, just kind of see all the rotation, just kind of see how it is," and that's kind of how I found my way to family medicine. So I definitely can reflect on or being from a family or having their father being a physician. So Shaina, let me ask you. Let me take you back to March. And so, what were you doing, academic wise, and how did you hear about it? And what was the whole change, or was there a big change to virtual learning as opposed to in-person learning?
Yeah. So in March, I was on my first day of my going to be ICU rotation. And then I heard that our rotations were going to be suspended. So I completely understand, I don't want to take PPE away from, people who need it. I know there's a shortage. But I was a little bit bummed that I wasn't able to experience being in the ICU. But so I feel like as a medical student right now, we're we're trying to be very nimble and flexible because things seem to be changing almost daily for us, just in terms of uh, different virtual learning that I mean, my school was pretty much, we have had online classes for a long time. We're a 3-campus school. And so the virtual part of learning was not new to me, but I think that adjusting to not being directly involved in patient care for a few months was tough. But I think, it's given me an opportunity to take advantage of programs that I may not have had the opportunity to. My school has taken the opportunity to come up with this program called the Open Book Project, where we've been coming together as a small group to reflect on COVID and how it affects people across the nation and across the world through poetry and art. And we've gotten a chance to do some writing, and I've done some reflecting through that project. And so that's been really nice, and I probably wouldn't have gotten that opportunity. But, I'm really just at this point, and I think my classmates too are just really trying to, uh, you know, absorb as much and learn as much as we can through our virtual modules. And my classmates, and I know other med students across the state are starting to go back into the clinical environment this month. So, it's kind of relearning how to be, working with patients and the clinical medicine aspect of being a medical student. So I'm excited for that to start up again. But yeah, I think it's you kind of are building skills that we're going to need for residency, the go with the flow and, being a team player and trying to figure out how you can make a difference given the situation that you're in. So I've really tried to take that approach with just all the changes that are happening right now.
So do you know when you're going to be, back in a clinical setting or back actually seeing, patients in person at any point?
Yeah, so some of my classmates have started this past week was their first week back. I'm taking a couple weeks to study for my step 2 exam, and then I'll be back towards the end of July, starting back at rotations. But yeah, I'm a little nervous to get back into it, but I know that like once I get going, I'll remember everything and it'll hopefully go pretty smoothly.
And this is your fourth year now. You're going to be a fourth year student now.
Yeah. Yep.
So do you know, like, how does the interview process look like, or do you have any idea like what that's all going to look like yet?
Yeah, so we've been told that all of the interviews are going to be virtual interviews. So we're getting really good at Zoom, and so I'll have to figure out how that'll all work. Like I said before, one of my audition rotations for residency is a totally virtual rotation. So part of that includes
Rotations.
Yeah, so I'll be doing some telemedicine, and my other rotations are like your standard inpatient rotations. So it's kind of a little bit of everything, which will be really fun, and it'll be kind of exciting to see how things go. And I'm excited to kind of take this next step and move forward with my medical school career.
Now, presuming, I mean, everything kind of works out academically. I mean, has you and your class been talking about maybe another, like virtual type of graduation or that type of thing?
Yeah, we haven't really kind of talked about it yet. I think we're all kind of hoping that things kind of settle down by next May, but I think that's something that, yeah, we're going to have to think about. This past year, the class had a virtual graduation, so I'm thinking it'll be. I'm a class officer of our class, so we'll have to think about what will make it special for us. And there's probably some lessons learned from the class before us on how to do that. So I think it'll just be us getting together and figuring out what ideas people have, and yeah, trying to make it as special and great as I know it's going to be.
So as we start to kind of wind things up here, so I'll start with you, Shaina, there. So if you have, I don't know, advice or things for medical students to kind of think about or look towards in this kind of pandemic world that we're in right now as you're starting your next academic year. I mean, do you have any words of advice, words of wisdom, words of inspiration just to try to get these students trying to get through this?
Yeah, I think one great resource that I've found is the American Academy of Family Physician website. They've had a good forum for medical students to keep track of how, like if you're applying to residency, how that residency process is going. And also the National Conference for Students and Residents is coming up in July, and that's always a really inspiring way to get involved and learn some really cool things related to family medicine. But in addition to getting involved and staying connected with your classmates, I think, yeah, just anything that we can do to kind of stay connected as a class and as a medical student cohort, I think really helps, especially when it can feel very isolating, or people feel like maybe they're alone. But I think that staying connected and staying involved can really help, and so that would be my advice.
Cool. And Mark, I'll give you the last word here. I mean, I know you work with learners, and do you have any advice, words of wisdom for learners during this time that's just to try to get them through the curriculum, or just how to cope during this crazy pandemic time?
I think if providers haven't given telemedicine a try, our experience has been that it only takes about 5 visits to get your not only feet wet, but feel comfortable with the platform. Getting over that initial hump is important, and then you can build on your skills as time goes on. But right now, there are so many opportunities to, because the rules have been relaxed, to get your feet wet. If you haven't been doing FaceTime visits, if you haven't been trying out Google Duo, if you haven't been trying out Doximity or Zoom, just pick one of them and start that way. And then you can broaden that. If you have patients who are technologically challenged, we can still use the telephone. And so do a telephone visit, for which there still is some modest reimbursement for. And get used to starting to see patients in that manner. Because if it dries up completely and people stop doing telemedicine, then there's no incentive for insurance providers, including CMS and private pays, to continue it, because they say, well, that it doesn't appear that the providers are actually demanding that this continue, because they've all moved back to their old bricks and mortar visits. And I think that would be a shame.
All right. Well, thank you so much. Thank you, Dr. Mark Rood. Doctor, thank you, soon to be doctor. Thank you so much for being here. I think we put up like our kind of closing slide that'll has some resources. There's Dr. Rood's article, and there's COVID-19 ABFM self-directed pathway, and there's information on our Ohio Academy of Family Physicians page, and some other links there. So, so stay tuned for July here on the OAFP Facebook page. We have some really exciting chats and interviews coming up in July. So thanks everybody for being with us, and have a good night, have a good week, have a good July 4th holiday coming up. So thanks everybody.
Thanks a lot.
Thank you. Bye.